Kamal Bhusal. I'm one of the faculty in endocrine section of internal medicine. Today we are going to discuss about primary aldosteronism as a possible cause of resistant hypertension, case detection, treatment, and follow-up. Primary aldosteronism is a group of disorder in which aldosterone production is inappropriately excessive and it is autonomous of the major regulator. And it leads to hypertension and that can cause in-organ damage and hypokalemia. It is also known as Cone syndrome. Among the causes, the most commonest cause is bilateral adrenal hyperplasia, which is about 60%, about 2/3 of the cases, and aldosterone producing adenoma and unilateral adrenal hyperplasia consist of about 1/3 of the cases, 35 and 2%. And among the rare causes, it can be a adrenal carcinoma producing aldosterone, or it can be a familial hyperaldosteronism, which is less than 1%, or you can have ectopic aldosterone producing adenoma or carcinoma. The prevalence, it was thought the overall prevalence of primary aldosteronism was less than 1% among all hypertension in the past, but more recent data suggests more than that, way more than that. And it is up to 5 to 10% of total hypertension. You can imagine 1 out of every 10 of your hypertensive patients can have primary aldosteronism. And that is because we are using aldosterone-renin ratio for diagnosis. And that is giving us more diagnosis. There are several studies, several data which suggests that the more prevalence in the recent studies. Among them, this is the one which was published in July 2016. As per this study, it says among the primary care provider, the primary aldosterone is around 3.2 to 12.7% among all hypertensive patients, and it is up to 29.8% in the referral center. This is another study which was published last year. It shows among all hypertensive patients, primary aldo is 5.9%, about 6%, and among them 65% is bilateral adrenal disease, and 27% can be a aldosterone producing adenoma, which is usually unilateral. And it also suggested there's more target organ damage and increased cardiovascular event with primary aldosterone as compared to essential hypertension. This is another, this is from the same study, based on what grade hypertension you have. If you have stage 1, it can be 3.9% of those patients can be a primary aldo, whereas in stage 3 hypertension, it can be up to 11.8%. This is another study which suggests about 81% of these patients, about 19% of these patients can have primary aldo if they have like stage 3 hypertension, and then about 7% if they have stage 1 hypertension. A similar finding, different study. All of them suggest we have more cases of primary aldo than we thought. That's why we need to do better job screening them. Let's start with our own patient. We had a 39-year-old female with past medical history of hypertension, vitiligo, arthritis, anxiety, focal segmental glomerulosclerosis, was referred by PCP for hyperthyroidism. Her medication list included lisinopril, hydrochlorothiazide, metoprolol, potassium 40, venlafaxine, sulfasalazine, adalimumab, and Tylenol. Her blood vitals was remarkable for blood pressure of 174/190 and heart rate was 96. And we reviewed the lab that suggests she had subclinical hyperthyroidism. That was the reason for referral. But it was also revealed that she had low potassium for a while. This is what we found. Look at her potassium. Since 2015, that was the earliest date she was here in our system, her potassium's been 2.5 to 3.5. What should we do next? Before we go to our cases, let's review some of the clinical presentation. How do they present? They are usually diagnosed between 3rd to 6th decades, and most common presentation is normocalemic hypertension with normal potassium. This is one thing we're missing. We always try to look for the potassium with hypertension, and if potassium is good, we don't worry about it. But most common presentation is normocalemic hypertension. And if it can be presented, they can present with hypokalemia, which is inconsistent finding based on the studies. 9 to 37% of total primary aldosteronism can have hypokalemia, and it is more common in primary aldosteronism who is taking adequate amount of sodium. And if hypokalemia is severe, they can present with muscle weakness, cramping, palpitations, headache, polydipsia, polyuria, and nocturia. And they can present with periodic paralysis very rarely, and it is more common in Asian population than the Caucasian population. And you will not find edema as a presentation finding in primary aldosteronism because of mineralocorticoid escape phenomenon. This study showed how many patients did not have hypokalemia who had primary aldosterone. Look at the diagnosis of aldosterone producing adenoma. 52% of those patients do not have hypokalemia. How about bilateral hyperplasia? 83% of them usually don't have hypokalemia. And other clinical features depends upon their in-organ damage. It can cause increased cardiovascular morbidity and mortality than primary hypertension. And left ventricular mass measurement, there will be greater left ventricular mass and greater LV dysfunctions, and it can cause increased events of MI, atrial fibrillation, and stroke. And we can find other indirect evidence based on this randomized control trial, which shows improved survival with MRA antagonist like spironolactone, we use in advanced heart failure, and in eplerenone, which we use in LV dysfunctions after myocardial infarction. This graph again shows you how common is left ventricular hypertension in primary aldosteronism. 54% of total patients can have LVS versus only 32% in essential hypertension. Look at the albuminuria, 27% in primary aldo versus 13% in essential hypertension, and 15% of increase the cardiovascular event in primary aldo versus only 6% in essential hypertension. And albuminuria is very common in primary aldo, but look at aldosterone raises GFR, and it increases renal perfusion pressures independent of systolic hypertension. That's why this is important finding. When you start treatment, actually your creatinine can get worse. And you can have mild hypernatremia. There will be volume expansion which resets the osmostat that regulates ADS release and host mechanism, and your sodium usually runs between 143 to 147. Rarely you can have hypomagnesemia for unknown reason, and if hypokalemia is severe, you can have muscle weakness, and you'll have increased risk of metabolic syndrome, including type 2 diabetes. How do we detect this primary aldo? Look at this 7 group of patients. If you find any of these patients in your clinic, order this test. The first group is somebody whose blood pressure is 150 over 100. More than 150 over 100 on 3 occasion in 3 separate days. You will screen for primary aldo. Hypertension resistant to 3 meds or control on 4 meds, you need to order for PA, primary aldo. Hypertension and spontaneous or diuretic induced hypokalemia. It is important here because when we look at the potassium is low, and we look at the medication, our patient is on diuretic, that's why potassium is low, and we forget about primary aldo. Order primary aldo on this group of patients also. And hypertension with any kind of adrenal incidentaloма, you need to order renin and aldosterone. And look at this 5th group, obstructive sleep apnea and hypertension. Don't forget this one. We usually miss this group. And hypertension and a family history of early onset of hypertension or CVA at young age of 40. And all hypertensive first degree relatives of patients with primary aldo. Look at the prevalence rate on this specific group of patients. If you have moderate to severe hypertension, 6.1% of them are primary aldo. If you have resistant hypertension, 17 to 23% of them are primary aldo. You have incidentaloma, it can be up to 2% of those cases have primary aldo. If you have OSA and hypertension, look at this rate, 34% of them can have primary aldo. That's why don't forget all this specific group of patients. What screening test? What should we do? Should we stop the medication they are on? And the answer is no. You can continue most of the medications, they are fine for screening. Because most of those medications causes increase in renin as well as aldosterone. And if renin is found to be suppressed, screen is valid. But if they are on spironolactone or eplerenone, you should stop them for about 4 weeks. But if you did the test and your renin is suppressed on spironolactone and eplerenone, then your test is valid. That's the real case. And best medicine to continue, if you decide to stop those medications, best medicine to continue is alpha-1 blocker and verapamil. And the best screening test is you do aldosterone and renin and calculate aldosterone-renin ratio. The exact ratio, there is no agreement on exactly what should be the cutoff point. Most of the people choose the ratio between 20 to 30, and if your aldosterone is more than 10, some people want at least aldosterone of 15 and ratio of 20 to 30 for diagnosis. This graph shows what will be your sensitivity and specificity based on what ratio you choose. If you choose 10, you're almost 100% sensitive, but your specificity goes down. That's why if you choose 20, your specificity would be 83%, sensitivity would be 78%. This is the one that most people chooses, aldosterone-renin ratio of 20. And this one, just for reference, if you have different unit given by your lab, then this table is useful. If it is given as nanogram per ml per hour for renin and nanogram per deciliter for aldosterone, then these are the ratio you're looking for. If you're choosing 20, this is 20, 30, and 40. Most people use 30. That's why it's bolded here. But if you have different unit, then you move to different table, just for reference purpose. And there is like 4 or 5 slides I'm going to show you briefly here that is mentioned in the Endo Society guideline. What are the ideal conditions for screening? You need to forget about all of this, because otherwise you're going to be intimidated with all this requirement and you're not going to do all these tests. I already said you don't need to stop any medication other than aldosterone and eplerenone. You don't need to find these ideal conditions. That means you'll never have ideal conditions. But if you have indeterminate diagnosis and your clinical suspicion is strong and your lab didn't go well with that, then you want to see this ideal situation. That's why I'm not going to spend a lot of time on these things. You should try to correct potassium, that is important, and you should ask patient to eat plenty of sodium when you're doing testing, and you have to be careful with hypertension and CHF though. And withdrawal agents that can markedly affect the ratio, that would be spironolactone and eplerenone. Remaining medicine can go. I'm not going to spend on that one. See, if your ratio is indeterminate, then probably you want to look at all these conditions which can affect your aldosterone renin ratio. But I don't want you to pay attention on all these things so that you'll do more testing. And all these medications can have effect on aldosterone and renin. Just forget about it now. And these are the medications you want to continue. If you have to stop those medications and blood pressure is high, extended release verapamil with hydrolysis so that you don't get tachycardia, and alpha blocker, any of these alpha blockers should be good. Back to our case. Remember these labs in our case? Potassium 3.5, 2.5 to 3.5. Her blood pressure was very high. She was on 4 blood pressure medicines, and she was also on 40 milli equivalent of potassium every day. What should we do now? Due to long-standing resistant hypertension and hypokalemia, it was decided to screen for primary aldo. And labs suggested aldosterone was 25.9, renin was 1.3, but not suppressed. Sodium 142, potassium was 3.2. What to do next? Calculate the ratio. And the ratio was 19.9. Remember 20? It's 20, right? 19.9. That means we have the positive screening test. Do we need confirmation for this patient? Probably yes. What are the confirmation testing and when do we need? It is not needed if your renin is suppressed less than 0.6 and aldo is more than 20 and you have spontaneous hypokalemia. If you meet these 3 criteria, forget about that confirmation testing. It's so easy. Your diagnosis is confirmed. So nothing can explain these 3 conditions other than primary aldo. But if you don't have these 3 conditions, like my patients, my patient had renin of 1.3, and that's why she didn't meet this criteria. That means we needed to do more confirmation testing. And what are those confirmation testing? One is salt loading, another is saline infusion test, fluorocortisone suppression test, and captopril challenge test. Salt loading test, you ask patient to eat or take more salt for 3-4 days, and you do 24-hour urine. You have to document urine sodium more than 200 so that you have the evidence the patient was taking plenty of salt, sodium, and if your aldosterone is more than 12, your diagnosis is confirmed. But if it is less than 10, it's negative. 10 to 12 is borderline. The same with saline infusion test. It's easy because you can do this one in the clinic. You give 2 liters of fluid, 500 cc every hour for 4 hours. You do aldosterone level, and after saline loading, if your aldosterone is more than 10, diagnosis is confirmed. If it is 5 to 10, it's borderline. If less than 5, it's negative. Similarly, fluorocortisone suppression test, you give 0.1 milligram fluorocortisone every 6 hours for 4 days and check aldosterone. If it is more than 6, your diagnosis is confirmed. For our case, because she didn't meet those 3 criteria, we did confirmation testing, and this is the lab. We have aldosterone 12.1 before we give the fluid, 20.8 after. Her potassium was a little bit low, 3.4. We tried to create like ideal situation. I gave 40 milliequivalent of potassium. In the beginning, as soon as I got the labs, and the potassium after the test, after the infusion was 3.6. What do you think on these labs? Does she have here? Is it confirmed or not? It is confirmed because aldosterone didn't suppress, right? It is more than 12, more than 10 is what you need after 2 liters of normal saline. And it is confirmed. And we have the case. Now you need to determine which adrenal is producing, what is the cause of this primary aldo. That's why the recommendation is do CAT scan for subtype classification. That is the first thing you will do after you have diagnosis of primary aldo, to exclude large masses of adrenal cancer and to assist intervention radiologists for AVS and surgeon if patient is going for surgery. If CAT scan is superior to MRI, that's why MRI is not needed. In CAT scan, if you find more than 4 centimeter adrenal mass, probably diagnosis is a cancer. But if you have bilateral thickening or micronodular changes, probably it's a bilateral adrenal hyperplasia. And typical of aldosterone producing adenoma would be 1 to 2 centimeter hypodense lesion, unilateral. Limitation of CAT scan, it will miss small aldosterone producing adenoma as a hyperplasia, or it can apparent adrenal microadenoma may represent areas of hyperplasia or non-functioning nodularity. And non-functioning nodularity are non-functional adrenal nodules are not uncommon, especially in older patients. That's why you cannot take it granted that if there is adrenal nodules, this is the one which is producing this aldosterone. And in unilateral adrenal hyperplasia may appear as normal in the CAT scan. The CAT scan, this is nice, normal right adrenal. You have left adrenal, looks like some nodules here, but it is labeled as a normal. And this is a large adrenal carcinoma which was producing aldosterone. And this was a nice example of small 1.5 centimeter hypodense right adrenal adenoma which was producing aldosterone. Back to our case, what did we do? We did CAT scan, right CAT scan, so this, left this, right, nothing much, left maybe nodularity, not sure, and it was reported as minor bilateral adrenal nodularity. It's too small to be fully characterized, and they favor macronodular adrenal hyperplasia. This is just I'm just quoting their report, and somehow it was repeated. I'm not sure why. But repeat CAT scan again, so sampling is nothing on the right, nothing, maybe a little bit thickening here on the left side, but it was reported as small nodules on the middle limb of the left adrenal gland measuring about 7 millimeter. What do we do next? If you're not sure about the CAT scan finding, like in our case, we do adrenal venous sampling to find out whether there is one-sided adrenal producing that aldosterone or it is the bilateral disease. And you should always refer patient to a experienced intervention radiologist. We may not have that, but we have some with some experience. And you don't need adrenal venous sampling if your patient is less than 35 years and you can find nice adrenal adenoma, aldosterone producing adenoma looking like feature in the CAT scan, 1 to 2 centimeter or unilateral hypodense lesion, and patient is less than 35, because it's very uncommon to have non-functional nodules in young patients. You don't need AVS, you can send that patient directly for surgery. The AVS is gold standard to distinguish unilateral disease from bilateral. Sensitivity and specificity is 95 and 100%, versus CAT scan has only 78 and 75% sensitivity and specificity. And how do we do AVS? Let's briefly describe AVS. It's something interesting. We can do with or without cosintropin infusion. We give cosintropin infusion just to exclude the other like stress factors and others, whatever stimulus you're getting, so that will not influence the results. And first you need to confirm the successful catheterization of both adrenal vein. You calculate the ratio of cortisol from adrenal vein to inferior vena cava or peripheral, and if that ratio is more than 5, then the catheterization is good. And that ratio, if you have not used co-syntropin test, then 3:1 is also good enough. And then after you confirm that successful catheterization, you calculate cortisol corrected ratio. Divide right and left adrenal vein by their respective the adrenal aldosterone level by their respective cortisol concentration, which will correct the dilutional effect of inferior phrenic vein flow into the left adrenal vein. There will be a difference between two adrenal vein in the concentration of those aldosterone. And if it is unilateral source, the ratio should be more than 4. If it is bilateral, then ratio will be less than 3. 3 to 4 would be borderline. And you can also notice, this is another thing, the contralateral suppression of the aldosterone from the normal adrenal gland. See, this diagram illustrates you nicely how difficult it is to do right adrenal venous catheterization. Look at the adrenal vein opens up directly into the inferior vena cava here, and the angle is straight here, versus left side, it opens, this adrenal opens first mixed with inferior phrenic vein. That's why you get dilated samples here on the left side, and then it opens up in the left renal vein and then inferior vena cava. That's why it's easier in the left side versus right side because of the location. Let's look at the example, how CAT scan can fool us. Look at these pictures. You have nice looking nodules here on the left side of the left adrenal. And this is AVS data. Right adrenal vein, aldosterone was 4,800, left 9,900, inferior vena cava only 526. Look, left a lot more than right. And you have here adrenal nodules, big nodules there. You calculate the first look at whether it's the catheterization is successful or not, whether these samples, these data are valid or not, whether you can proceed further or not. You calculate cortisol ratio from inferior vena cava and adrenal vein. If it is more than 5, you're good. Look at the right adrenal vein and right adrenal vein 9,200 and inferior vena cava 1,400. The ratio is 6.4, and the left side 7.7, meaning this is valid results. The catheterization was successful. Is it lateralizing to one side? Look at the aldosterone cortisol ratio here. Right side 0.52, left side 0.89, peripheral or inferior vena cava 0.37. More on the left side, but what is the ratio here? 1.71. Is this unilateral disease or bilateral disease? We need at least 4 ratio. Less than 3 would be bilateral disease. That's why this is bilateral. Look at, and you remember that this was fooling us, was left-sided large nodules, but disease was bilateral. Let's look at another example. It has nodules on the right side very small, left side a little bit larger, bilateral nodules. And this is the AVS data. Was catheterization successful? The ratio is 46.3 and 40.9, cortisol ratio, meaning successful catheterization. And is it unilateral disease or bilateral? What's the lateralized ratio? 23.8. This is unilateral disease. Right adrenal vein is producing this aldosterone. Look at the CAT scan. The right is smaller than the left one. If you had just believed this CAT scan, you would have removed this one probably. That's why AVS is very important. CAT scan can be misleading. What happens if AVS is unsuccessful? You could not catheterize, you tried, then your option is repeat AVS or treat patient medically or consider surgery based on other findings. And is there any test if ABS is unsuccessful to localize the lesion. There are some, but it's not commonly tested, and there's not enough data, and we don't rely on these things. One is posture stimulation test, cholesterol scintigraphy, 18-hydroxycorticosterone levels. Apparently, aldosterone producing adenoma produces more 18-hydrocorticosterone levels, and C metometed PET scan. We're not discussing in detail on those. How about our case? What happened to her? We confirmed her disease, and we did CAT scan. It didn't show anything, and it was not confirmatory. And we sent her for ABS, and this is the picture from the ABS, right and left. Look at this picture matches with what we had in the diagram, right? And we got the data. Let's look at the data. Her right adrenals was producing 500, aldosterone level was 512, left was 8,800, and peripheral was 29. And first we looked at whether it was confirmed catheterization or not. Look at the ratios, more than 5 on both sides. It was confirmed, and the lateralization ratio was 15.28. And with this ABS, we can confirm that her left adrenals was producing too much aldosterone. And we also have documentation here. She had suppression on the other side of the adrenals, normal side. Look at the peripheral ratio was 1.33, and right side was 0.97. It's only 0.73. Less than 1 is suggestive of contralateral suppression. We have successfully lateralized that this is left adrenal disease. What are other tests we need to consider if it is bilateral disease, or if patient is having primary eldo on less than 20 years of age, or in those who have a family history of primary eldo or strokes at young age, less than 40, you need to test for the genetic mutation, genetic testing for glucocorticoid remedial aldosteronism. And if you have very young patients with primary eldo, we can test for more genetic mutations. But we don't have to test any mutation for other primary eldo. Now treatment. The goal of the treatment is to reverse the cardiovascular risk, to normalize potassium and blood pressure. The blood pressure might persist. Treatment for unilateral disease, like our case, is surgery, and preferred surgical treatment is laparoscopic adrenalectomy. And what happens after surgery is your blood pressure will improve. Up to 50% of cases it may disappear, but up to 40 to 65% it will persist, but with lesser degree. You'll need less medications, and it depends upon if they had underlying primary hypertension or they already had nephrosclerosis. And it will take up to 6 months to normalize blood pressure. Left ventricular mass. The effect on left ventricular mass was equal with surgery versus medical management. And the quality of life measure improved based on one study for sure. I will show those data here. And we don't recommend any, as the guideline doesn't recommend any ablative procedure. They recommend adrenalectomy. And this is the one set of data which shows what happens after surgery of primary eldo. Everything improves. Look at the p-value. Look at these numbers. Everything improves. If they were on 2.7 blood pressure medication before surgery, they were on only 0.1 meds in average. And this data shows whatever they tested for quality of life measures, everything improves. Look at the p-values, everything improved after surgery. This is we try not to mention, or we don't care most of the time, and we're just worried about blood pressure and everything, and if blood pressure is good, we don't try to do further testing. And this is the data that shows the surgery versus medical management, the LV mass change was almost equal. Slightly more improvement on the surgical side, but more or less equal. If you're sending patient for surgery, what do you need to do? Pre-operatively, you have to control high blood pressure before they go for surgery and normalize potassium level. And post-operatively, after you remove the the adrenal, you need to stop potassium supplement, discontinue spironolactone or eplerenone, and reduce blood pressure medications. And check aldosterone renin to see if it has improved or not. And you need to tell patients to eat plenty of sodium, because remember, you can have contralateral adrenal suppressions, meaning you can develop hypoaldosteronism now because the active part is gone, and for a few days they have to eat plenty of salt, and you may have to discharge them on low dose mineralocorticoid also based on how they do. What happened to our patients? We sent her for surgery. We started her in spironolactone and referred her for surgery, and she underwent laparoscopic left adrenalectomy here, and pathology showed nodular hyperplasia. Now, what is the treatment for bilateral disease? It's medical therapy. Surgery is not recommended. Too many comorbid conditions, benefit is not more than harm with bilateral adrenalectomy. That's why surgery is not recommended for bilateral disease. And if you have patients with glucocorticoid remedial disease, and then you'll start with the low dose steroid on those patients. First line treatment, mineralocorticoid antagonist. We have two medicine available. One is spironolactone, which is drug of choice. Another is eplerenone, which is newer but more expensive and has fewer side effects. Both are equally effective, and you need to monitor potassium level, creatinine level, and blood pressure, especially for first 4 to 6 weeks. You cannot start on this medication and see in 6 months. Spironolactone is also a progesterone agonist and androgen receptor antagonist. That's why you might find breast tenderness and menstrual irregularities if your patient is young. And in male, you can have impotence, decreased libido, and gynecomastia. Whereas eplerenone is very weak. They have very weak affinity with androgen and progesterone receptor. That's why none of those side effects occurs. But half-life is short, and you need BID dosing. Always start with spironolactone, and if side effects are limiting, then switch to eplerenone. And if you can't give those medications, both of those medications, but when your blood pressure is high, then you have other options. Amiloride and triamcinolone, they are not effective like spironolactone and eplerenone, but you can try these medications. And if blood pressure still persists, use other blood pressure medicine, including thiazide diuretic and ACE inhibitor. Now, what do you do for monitoring? With each medication change, you need to monitor for blood pressure, creatinine, and potassium level. And you'll do that more frequently for the first 4 to 6 weeks of medical therapy. And how about renin level? Do we need to order aldosterone and renin after you start treatment? This is what we do in other cases, right? Like hyperthyroidism, we start methimazole and we follow TSS, and we keep on adjusting medicine until your TSS is good, right? How about here, renin level? Renin is suppressed. It's equivalent to TSS in hyperthyroidism, right? This is something new concept, and there are some data coming, and they're comparing, the complication for somebody who's medically treated for primary aldo based on their renin levels, suppressed renin versus detectable high renin, more than one renin. This was published this year in Lancet Diabetes earlier this year. Again, this first table shows same thing like we already mentioned increased risk of cardiovascular disease and mortality in primary aldosteronism versus essential hypertension. And this table shows primary aldo treated with mineralocorticoid receptor antagonist had nearly twofold higher unadjusted incidence of composite cardiovascular event compared with patients with essential hypertension. And the adjusted hazard ratio was 1.91, still 2 times. Look at the graph here. This one with essential hypertension. This is primary aldo treated with mineralocorticoid receptor like spironolactone. But if you compare that one with, in terms of renin level, suppressed renin versus not suppressed renin. So this is not suppressed, this is suppressed renin, and this one is higher renin, more than 1 renin. Where is it? Yeah, more than 1 renin, adjusted versus unadjusted. You have significant difference in cardiovascular event based on renin level. 3 times higher risk for cardiovascular events and significant higher risk of death. By contrast, unsuppressed renin was not associated with a significant difference in incidence of cardiovascular events or death versus with patients with essential hypertension. And there is no significant difference based on aldosterone levels. They also compared with the aldosterone level before you start treatment. Very high aldosterone level versus not that high aldosterone level. There's no difference on that one. It was all renin. If renin is suppressed, you have significant primary aldo. Like if your TSH is suppressed, you have not controlled hyperthyroidism. And they also, we don't have the graph, but they also compare patient who was treated surgically for primary aldo, and they had significant low risk of incident, 0.58 adjusted hazard ratio as compared to essential hypertension. This is something new which we never do, until now we haven't done. I'm starting to check renin level for somebody who is on mineralocorticoid receptor antagonist to find whether we are treating that patients adequately or not. We used to follow only potassium and blood pressure, but this is something new. On that, the study's conclusion, same thing. Study suggests that concurrent practice of using MRA for primary aldo is associated with an excess risk for cardiometabolic outcome and death, atrial fibrillation, and diabetes compared with patients with essential hypertension, and targeting a rise in plasma renin activity as a biomarker for adequate mineral MR blockade might serve as an important clinical benchmark in treatment of primary aldosteronism with MR antagonist. Let's go back to our patient. What happened? She went for surgery. What happened to her blood pressure and potassium? We saw her 8 weeks after surgery. Her blood pressure was fairly controlled with only 2 medications versus 4 or 5 medications before surgery, metoprolol and amlodipine, and her potassium normalized without any supplementation. And we had 2 sets of lab here, 8 weeks and 16 weeks after surgery, and her aldosterone was normal, renin was not suppressed, and potassium was 4 and 4.4. Pretty good. Now what's in the future? What we can wish for the future? Maybe we should have our 3rd generation mineralocorticoid receptor antagonist, which is non-steroidal, as potent as spironolactone and as selective as eplerenone, so that we would not have side effect. And maybe we should have a selective aldosterone synthase inhibitor, meaning we'll have less side effect. And maybe a 4th generation mineralocorticoid receptor antagonist, which is non-steroidal, potent, selective, and tubal sparing to lessen the extent of elevating plasma potassium for additional use of MRA in the case of heart failure and fibrotic disorders. To summarize what we discussed, everything, this is chart from the up to date. remember this 7 group of patients for screening primary aldo. Remember, you don't need to look for hypokalemia, okay? And the test you would do is aldosterone and renin together and look for the ratio. Ratio more than 10 would be suggestive. More than 20 is what you're looking for, which suppress renin. And if you have primary aldo more than 10 and suppress renin, then you look at patient's lab. Does patients have a spontaneous hypokalemia? Because diagnosis is confirmed, screening is, screening is positive here. If patient have spontaneous hypokalemia and aldosterone is more than 20 and your renin is always suppressed, you don't need to do confirmatory testing. Diagnosis is confirmed. Okay? But if you don't have these 3 things, suppressed renin and more than 20 of aldosterone and spontaneous hypokalemia, then you need to choose one of these confirmatory testing, or you might simply refer case to us. And those confirmatory testing is 24-hour urine aldosterone with high sodium diet intake, fluorocortisone suppression test, and saline suppression testing. And if your aldosterone is less than 10 and renin is more than 1, it's not primary aldo. After you confirm the case, you need to find out whether it's unilateral or bilateral disease. First test you would order is CAT scan. If CAT scan is normal, or it shows micronodularity, or it shows bilateral mass, or the mass is atypical, and if patient doesn't want surgery, start the treatment, mineralocorticoid receptor antagonist. But if patient wants surgery, send that patient for adrenal venous sampling to find out which one is producing more, if it is unilateral disease. If it is lateralized, if it is unilateral disease, send that patient for surgery. But if it doesn't lateralize, meaning it is bilateral disease, start mineralocorticoid receptor antagonist. But in the CAT scan, if you have typical lesion of 1 to 2 centimeter, and you have significant hyperaldo, and patient wants surgery, look at the age, more than 35, less than 35. Less than 35 don't need adrenal venous sampling, because non-functional adenoma in young age is very uncommon. That patient will directly go for surgery. But if age is more than 35, that means they can have incidentaloma also, then you need to do adrenal venous sampling. If it lateralizes, patient goes for surgery. If it doesn't lateralizes, meaning bilateral disease, start medical management. But if patient doesn't want surgery treatment, even if it's so typical, then you start treatment with medicine. Any questions? All right, thank you.